All right, so this is part 1 of 4 of a lecture I gave not too long ago called Trauma Resuscitation Updates. Now, I've written a blog post on RebelEM, and you can read if you would like, but I find that most people are starting to like watching videos, and so that's why I decided to break this up into 4 digestible parts. So for this video, we're going to do part 1. Now, when we talk about goals of trauma resuscitation, there's really 4 things that we're focusing on. We want to minimize iatrogenic injury from the resuscitation itself. We want to control bleeding, get that hemorrhage control. We want to promote hemostasis to avoid that trauma-induced coagulopathy, and then we want to restore perfusion. And so for this part, we're going to talk about the first thing here, which is minimize iatrogenic injury. So how do we go about doing that? So the first thing I want to talk about is this concept of permissive hypotension. And this was a trial of about 100 patients, and it's titled Hypotensive Resuscitation During Active Hemorrhage, Impact on In-Hospital Mortality. Now, this is a bit of an older study, but basically patients got randomized to targeting a systolic blood pressure of 100 versus targeting a systolic blood pressure of 70 millimeters of mercury. And what the authors ended up finding is there was no difference in mortality. And so then the next question is going to be, what is the best systolic blood pressure map that we should target? Now, if you ask my opinion, I would say in most trauma patients, if we can get to between 70 and 90, we're doing pretty well for our systolic blood pressure. If we can get to about, 55, 60 on our map, we're probably doing okay, with one exclusion, and that's traumatic brain injury patients, which I'll come back to. But the problem with having an actual goal to target is that you run into this problem of over-resuscitating your patients. And so I think that the strategy that you're using is way more important than a specific number or goal. And this is what I'm getting at. It's this concept of cyclic hyperresuscitation. So patient comes in, they're in hemorrhagic shock from trauma, they have a low blood pressure or MAP. What do we do as good physicians and clinicians? We resuscitate the crap out of them, and we get their blood pressure normal and we get their MAP normal. Well, then what ends up happening is they start bleeding more, and then they get a low blood pressure or MAP, and then we have to re-resuscitate them. And so it becomes this like futile cycle of like, we're over perfusing them. And so when I say strategy, I'm talking about things like looking at their mental status, looking at their cap refill, looking at their urine output, looking at lactate trends. I care more about those sorts of things than an actual hard number. But if you're going to pin me to it, systolic blood pressure between 70 and 90 is usually my goal, again, with the exception of traumatic brain injury patients. Now, what about the amount of crystalloids that we're giving in these patients? And I think, back in the day, we used to just give liters and liters of fluid. And I think there's a lot of evidence now that that's actually not good and can actually be a lot worse for our patients. If you thought the last paper was old, this paper is even older, from 1994, published in the New England Journal of Medicine. And this was looking at immediate versus delayed fluid resuscitation for hypotensive patients with penetrating torso injuries. And so here's what their fluid strategies were for fluid resuscitation. So there was giving them fluids immediately in the pre-hospital world versus delayed, which they called in the OR. So how did this study pan out? Well, it turns out that the patients in the immediate group that got lots of fluids got almost a liter of fluid, and the ones that were delayed only got about 100 cc's. So there's definitely separation between the two groups. And what they ended up finding is that giving them even up to a liter of fluid, this isn't even quite a liter, it's just under, increased mortality, complications, and hospital length of stay. And so I think this is why a lot of us are starting to try and avoid giving liters and liters of fluid, and now starting to do little aliquots and replacing what's actually lost, which is blood products. What about vasopressors to kind of help you with your perfusion and systolic blood pressure and MAPs? And classically, vasopressors haven't been given in trauma, and the thought is because of peripheral vasoconstriction that you could potentially worsen ischemia to end organs. And so this is a rather controversial topic, and I found 2 papers on this. The first one was just a narrative review that looked at vasopressors in trauma, a never event with a question mark. And they went through all the evidence that they could find on vasopressors. And their conclusion was actually kind of a funny one. Shock in trauma patients is complex. Well, no kidding. And it's controversial and it requires a nuanced approach. And what they were getting at, if I dive in a little bit deeper into this paper, was that there's really two phases of shock in these patients. The first is compensated and the second is decompensated. So in the compensated, patients are able to keep up with an increased heart rate. They're able to clamp down peripherally and kind of shunt blood flow. And giving those patients vasopressors could be potentially harmful and decrease perfusion. Now in the decompensated ones, the ones that are vasodilated and not improving, those are the patients that might gain benefit from vasopressors. And that's, at least in a simplified way, what the authors of this narrative review said. Now, there is one randomized clinical trial looking at this matter, and it's called the AVERT-Shock Trial. And it looked at low-dose supplementation of vasopressin on need for blood product transfusions in patients with trauma and hemorrhagic shock. And this was actually a randomized clinical trial. It wasn't a very big one, but basically to be enrolled into this trial, you had to have greater than or equal to 6 units of blood products in 12 hours. You had to already have definitive hemorrhage control. And then after that, you got randomized to vasopressin as a bolus plus a drip versus placebo bolus plus a drip. And the MAP that you were targeting was greater than or equal to 65 millimeters of mercury for at least a continuous 48 hours. And what they found is that the use of vasopressin certainly decreased the amount of blood products needed at 48 hours, but it really had no difference on mortality. Now, the mortality outcome was a secondary outcome, and so the study's not powered for that. It certainly wasn't big enough, but just one of those things to know. But I certainly think decreasing the amount of blood products we give to patients is a rather important outcome. Now, I told you I'd come back to this, what we target in traumatic brain injury patients. And I pulled 2 papers on this. The first one was just in rats, which are not humans, but this was an interesting study because what they did is they took 48 rats, they gave them iatrogenic brain injury, and then they kind of bled them out to give them a low blood pressure. And then what they did is they resuscitated them to a target MAP of 80, 100, and 120. And what they ended up finding is that neuro outcomes and mortality were inversely correlated to the MAP target. And so what do I mean by that in layman's terms? Basically, targeting a lower blood pressure, these rats did better neurologically and from a survival standpoint. Now, what about humans? Because that's what we care about. We don't care about rats. And this was a paper that is not a randomized clinical trial, but it's a really big paper. It's got over 7,000 patients, association of out-of-hospital hypotension, depth, and duration with traumatic brain injury mortality. And so this was 7,500 traumatic brain injury patients. And the groups, again, not randomized to, but the cohorts that they put them into were systolic blood pressure greater than or equal to 90 versus what if their systolic blood pressure was less than 90. And what they found is that a lower blood pressure is associated with a higher mortality. So here's the kind of conclusion of minimizing iatrogenic injury in trauma patients with hemorrhagic shock. So permissive hypotension, remember, your strategy is going to be way more important than targeting a specific goal. Crystalloids, we really want to try and minimize these, but if needed, I would do maybe 250 cc's at a time, kind of reassess the patient. I certainly wouldn't go over a liter. Vasopressors, I think it depends on what phase of the trauma and resuscitation you're in. I don't think there's an absolute here that says don't give vasopressors, period, but be careful early on when these patients are compensated because you could potentially worsen perfusion. And then traumatic brain injury, I think the blood pressure target here is controversial. I think most people who are practicing in trauma centers would tell you that we should probably be targeting systolic blood pressures of greater than 120. I may be being a little bit conservative with that. I've seen people target greater than 100, and I've talked to neurosurgeons who say we should definitely be targeting greater than 130. I think this is going to be system and institution dependent. The evidence is really kind of all over the place. But again, another reason why I just don't care about the goals. I care more about the strategy of what we're doing. So there you have it, part 1 of trauma resuscitation updates. Leave me your thoughts, comments, and questions. Thanks for watching, and until next time we'll get into part 2 of trauma resuscitation updates.